All right, so we're gonna now talk when these leaks become chronic, and that's where the story really starts. Because the patient is now somewhere in the community. You're not necessarily following what's happening 5 years, but the cases or the case that I chose to present will highlight the difficulty in managing chronic leaks after sleeve gastrectomy, which to me, they're equally important, and you have to have a high degree of vigilance because they could be very challenging, and I think the case will demonstrate that. So this is a 42-year-old male, status post lap sleeve, day 5, developed tachycardia, very high CRP, temperature of 39.3 Celsius. CT scan shows a leak, and you could see that the leak is starting to contain even that early after the leak initiation, but there's no hyper-enhancing wall and still not fully formed leak. This patient is tachycardic, WC count, they're sick, so the management strategy was percutaneous drainage and diversion rather than internal draining. Because if you're draining, if a collection that's not fully formed, you're in the peritoneum by default. So here we chose pigtailed percutaneous drain and placement of a stent to bypass this area, and we sutured that stent in place to create a seal so the oral secretions are bypassing the area of that leak. So patient did well. 4 weeks later, you come. Now this formed to become a chronic fistula. You could see the fistulizing tract, and you could see the percutaneous drain sitting in this cavity. But remember, 4 weeks later, this patient still relying on TPN. And now you need to say, how could I advance this patient diet? The patient's getting fatigued from this complication. So here now you have a dilemma again. You have a percutaneous drain on bulb suction that you're going to feed the patient. Everything that you're going to feed the patient with is going to go through the percutaneous drain. So the path of freeze resistance becomes where the water flows, and you're stuck with a problem here. So our management approach is we wanted to isolate the pressure gradients at this point and try to remove that percutaneous drain while maintaining internal drainage. So we switched from a diversion strategy to figuring out how to maximize the pressure gradient, so we are isolating the percutaneous tract and draining things internally. So we resort to this Gore plug. They use it for hernia repairs. And this is a bioabsorbable that provide a matrix. We used it as a plug to plug the percutaneous tract. So we're isolating that chamber. Not really to plug the leak, sleeve leak, but to allow us to plug the percutaneous tract, remove that percutaneous drain that we had to place because the patient was sick, and now manage this with pigtail drainage internally. So isolate the pressure, that's the concept here, isolate the pressure. If you have percutaneous drain, you cannot drain internally with both of them. And then now once we plugged that tract, that goes to the percutaneous tract, we had a closed system. Now we put pigtails to drain things internally because we got over that pressure gradients. Patient did well. They had some kink in the distal part of the sleeve. You could see that there's narrowing or stricture. So we used pneumatic balloon dilation to dilate this area to 30 millimeter. Again, there's two types of balloon. There's the hydrostatic based on pressure of fluid that goes up to a diameter of 20. They do not work well in this situation. And there's the pneumatic balloons that goes to PSI of 20, and they go to 30 and 35 millimeters, and that's what we used here. And after that, the patient was able to resume oral intake and did well for 6 months. 6 months, comes back describing some cough with eating. The PCP got an upper GI series that shows no residual leak. You could see the leak cavity has collapsed, but that combination of the patient coming cough with eating, recurrent admissions with pneumonia triggered a flag that we, despite a negative upper GI series showing no leak, we did an upper endoscopy, and not just an upper endoscopy, you have to do an upper endoscopy. What you're seeing here is an ERCP occlusion balloon and a wire. We're probing at the area where the leak has healed and using this wire, and what you've seen here is this wire is going to a place that should not be going, and you're seeing it coming out of the patient endotracheal tube. So that's a chronic fistula between the sleeve and the pleural space going into the distal bronchus, and the patient has a real big problem at this point. So there's no such thing as internal drainage at this point. So you're embarking either at a big surgery, reconstructive surgery, or you're gonna have to figure out how to isolate the pressure from the intrathoracic to the intra-abdominal pressure. She was young and she did not really want to go on another big surgery. So the idea after a multidisciplinary team discussion was to try to do what we can endoscopically, knowing that if we failed, she's gonna progress to a big combined thoracic abdominal surgery. So this is the phenomenon that you see. The leak has healed, but you had the fistula going to the lung. So what we did here in this situation, we utilized the septal occluders, off-label use of this device. This device is designed to epithelialize a muscular structure. So for this to work, you have to finesse it with wire guidance to get it across the diaphragm. And you could see from the radiograph, we were able to get this with its proximal end in the distal bronchus, its belly across the diaphragm, and its distal end into the intra-abdominal portion. This allows the structure, the muscle, to epithelialize, to occlude that defect to the diaphragm, and then we drain the intra-abdominal portion endoscopically to manage this patient. And we did this successfully, but the questions to the panel, how would you approach this differently? And the big plug is, do not lose follow-up with these patients, because these fistula happens years later. Even though you have every confirmatory test that shows no leak, these fistula could fester and come back representing like this years later. So keep a high degree of vigilance. So let's go across the panel and see how would you have managed this differently. Tammy, you could start.
I'm sure the audience also is quite impressed with the endoscopic options that you're able to provide there. I'm not sure that we would have been able to try to do quite that. So I probably would have been at quite a big surgical resection with what would have been like a subtotal sleeve, resection to a Roux-en-Y if I could get a little bit of proximal cuff, but I would have wanted to get rid of the distal obstruction, and then obviously having to manage the chest as well and drainage and resection. So really tough situation.
Same. I think the beauty of having a session with Dr. Abu Dayyeh is you learn new purposes for every instrument that's out there. I never would have thought of that. It's amazing. I would have been planning an esophagojejunostomy on this patient.
Yeah, Barham, that's a great case. I love the use of the occluder that we use for complex fistula after esophagectomy too. The one thing that you pointed out, and I think is the most important teaching point, is that you have an obstruction to flow there and high pressure system. So I would have been, I think, a little bit more prompt to divert the patient with a Roux-en-Y. What I would have done, because that's the only alternative, we know that dilation, even with the achalasia balloon, is not so effective and you require multiple dilation session. I would probably, with such a big cavity, try asymptotomy to really try to lower the pressure before anything else. But for bronchopulmonary fistula, I have a very low threshold to convert them because they tend to recur no matter what you do.
I don't have any of the access to the kind of endoscopic techniques and such. It's very impressive. And we don't have thoracics either. I would look at this probably the way Dr. Kindle and Dr. Hussein would at earlier conversion to a Roux-en-Y, or if it was extremely hostile, consider a fistula jejunostomy, although I've not done one of those.
Very complex case, I think, and the important thing about this case is, like, if you're in a community hospital, you should refer this patient to a center where they can take care of this. Definitely, you have different options, more advanced techniques. I would have diverted her esophagojejunostomy very early on, 26 years old, taking chances, going back 3, 4, 5 times. I think that it's easier for me to do an esophageal or a gastric bypass if I have enough length. But important thing is to refer this patient to someone like you, not like me.
No, the message is to a multidisciplinary team that could provide all the options and go back and forth, because it's 26 years old, and every breath is going to create a negative pressure gradient back to the chest, and that's the big problem that you're dealing with. All right, nice discussion. Off to the definitive management with Dr. Hussein.